Hi, everyone, and thank you for joining us today. My name is Giselle Corletto. I'm with the USC Military and Veterans Programs. Today, in recognition of Suicide Prevention Month, we've lined up a special agenda. It is my pleasure to introduce our first guest speaker, Dr. Sharon Birman. She is the Chief of the Suicide Prevention Program at the West Los Angeles VA. Sharon, you may start.
Good morning, everyone. Thank you, Giselle, so much. I think I'm going to need your help one more time in making me co-host so that I could share screen again. It looks like I was booted off for a moment. And if in the meantime, just so that I can make sure that folks can hear me all right, can folks slap me some Y's in the chat box just to let me know then you can hear me okay? So go ahead, just type a Y, raise your hand. Thanks, Stephanie. Perfect, wonderful. Thank you so much. All right, well, good morning. I will go ahead and share my screen with you guys in just one moment so we could get our slides here up and running. Perfect. Can folks see those slides okay? Perfect. Wonderful. All right. Well, thank you so much, everybody. And thank you for your patience with me with these morning technical difficulties. So I'm really excited to be here today, particularly as September really does represent Suicide Prevention Month, really an issue that has kind of been a little behind in the field of psychopathology as compared to other areas in psychology, and really has garnered quite a bit of attention in the last decade as suicide rates have continued to increase in our active duty community, in our National Guard and Reserve community, in our veteran community, even in our civilian communities. We continue to see these rates continue to rise up. So I'd like to talk a little bit about the Mayor's Challenge and what a team of folks, the stakeholders in our community, have really done to come together to try to really tackle this issue to prevent suicide among service members, veterans, and their families. Before I do that, I want to take a little bit of time to delve into the epidemiology, and I know that our time here is incredibly limited, so I'm not going to bore you guys with too much statistics, but I do think that getting a little bit of a gauge of what is happening kind of nationally, what's happening in our veteran community, what's happening in our state, as well as here in LA County, gets us a little bit grounded in the numbers to give us a better understanding of what is the problem at hand and what should we start to even do to consider tackling it. When we look at our national rates, more than 47,000 Americans die by suicide. It's about 47,300 in the most recent year. Just for you guys to get an idea, when we're looking at suicide data, because the data is retrospective in nature, it tends to have a little bit of a lag. So the most recent data that we tend to have is usually about 1 or 2 years behind. We need to finish the calendar year in order to collect, for example, all of the deaths in 2020. Then that data is analyzed and better understood in 2021 and usually not published till about 2022. So there tends to be a little bit of a lag. The most recent stats that we have for our national rates come from the Center for Disease Control, and those are representing the year 2017. So when I say 47,000, we're looking at 2017, which really lends suicide to be the 10th leading cause of death in the United States. Imagine how crazy that is to think of a behavior that is self-inflicted. It's really kind of considered by the CDC to be a violent death and is considered to be a self-inflicted violent type of death. So to think about that as compared to the other leading cause of death, such as cancer and so on and so forth. So really the 10th leading cause of death, the second leading cause of death for the age group between 10 and 34, and the fourth leading cause of death for the age group of 35 to 54. This means that about 63 Americans die each day here in the United States. That's equivalent to a suicide happening here in the US every about 11 minutes. I say these statistics, I present this type of data all of the time, and yet it kind of gives me goosebumps every time I present these rates, because just to think of how many lives lost to suicide just over a course of a 2-hour talk that we're engaging, several lives lost here in the US. It's interesting that the rates have been climbing. So we're not yet looking at veteran rates. We're not yet looking at active duty rates. We're just looking at our civilian national rates, including veterans, including civilians, just everybody together here in the US. And we see that the rates have been increasing pretty significantly, representing about a 30% increase when we look at the years 2001 all the way through 2017. So significant increase that we tend to see over the course of those years. So just kind of to get an idea of these numbers again, just to kind of ground us in what's happening right here in the US. I think it's also important to consider that suicide accounts for more than twice as many deaths than does homicide. In fact, here in the United States, suicide rates are higher than homicide and war-related deaths combined, so a really significant problem. And when we look at our kind of individuals at risk, we tend to see over the course of the years that males tend to be much more likely to die by suicide. The numbers range over the course of the years anywhere between 3.5 times to 4 times as much as females, whereas females tend to attempt more. So certainly a problem amongst both males and females, but we see that suicide deaths occur much more frequently in our male kind of folks at risk, which our veterans tend to be comprised mostly of a male population. So just kind of keeping that in mind. Now, as we shift gears and we really kind of delve into our veteran statistics, I think it starts to kind of provide a really interesting picture. A lot of the information that is presented on this slide comes from a really interesting report that was published in 2016 out of the Office of Suicide Prevention out in VA Central Office. And this was really a study that was unprecedented in the kind of comprehensive nature of this study. It was just absolutely huge. They looked at 55 million records over the course of several years. They looked at 55 million veteran records all the way from 1979 to 2014 to really try to analyze and better understand the suicide rates in our veteran population. And this study was particularly unique in that VA Central Office worked collaboratively with the Centers for Disease Control to get a larger population base. So up until this point, VA was really trying to better understand suicide rates by looking internally into their electronic records, really getting a better understanding of those veterans who were utilizing VHA healthcare systems. And yet we know that not all of our veterans are utilizing VHA healthcare. And so by collaborating with the CDC, we were able to get a more comprehensive view, a more accurate view of our veteran population, accounting for both those individuals who were utilizing VHA healthcare and those who were not. So again, 55 million records. And what they found was that every day 20 veterans die by suicide. A little bit different than that 22 number. There are a couple of things that we need to keep in mind. When we look at this number of X amount of veterans per day, I'm always a little bit hesitant to present that, whereas it's one of those numbers that I think really help us to remember and understand kind of what's going on in the moment. I think it's also important to really kind of consider the context. And what we see is that over the course of the years, our veteran population is shrinking. So as these numbers shift from 22 to 20, it's possibly representing a more accurate data presentation because we're getting kind of those numbers from the CDC and from VHA, but it's also possible that what we're seeing is a representation of a shrinking veteran population. Nowadays in the US, veterans comprise only 7.6% of the US population, less than 8%, and yet they comprise 18% of US suicides. So while they're a shrinking population, they're representing a much larger proportion of the suicides that would make sense. In the veteran population, again, not surprising, similar to civilian population, what we see is that suicide makes up a larger number than homicide and war-related deaths in this population. Now, the the standardized suicide rate for veterans, and we tend to look at this as an N per 100,000 so that we can compare this based on a population-based number. So as our population in the US, as our veteran population shifts from year to year, we want to compare this in a standardized suicide rate so we have an accurate representation of the numbers and that we're comparing apples to apples over the course of the years. And what we see is that this rate is 30.1 per 100,000. I want to turn you guys back to the previous slide for just a moment, looking at our US population rate, which shows that in the US the rate is 14 per 100,000. So our suicide rate in the United States is 14 per 100,000, and yet our veteran suicide rate is 30.1 per 100,000. Really, really, really big difference, showing that veterans are at 1.5 times greater risk for suicide than their civilian counterparts, even when you account for age, demographics, gender, and so on and so forth. What's particularly interesting is that the suicide rates in our veteran community tends to be highest among those individuals between the ages of 18 and 29. So our very, very, very young OEF, OIF, OND veterans are coming back at higher risk. Now, I know that today in the audience, there are some folks that are mental health providers. Go ahead and slap me some Y's if you're a behavioral health provider. Social worker, psychologist, psychiatrist, mental health nurse, peer support, if you're in any way involved in behavioral health. Many of you guys have probably already learned over the course of your studies, maybe grad school, maybe in some of your training and supervision, that in the United States, our most vulnerable population tend to be older white males. I heard this ad nauseum in my grad school, maybe some of you guys did too, but older white males over the age of 65, they're the folks that tend to be most at risk. And yet what we see here in our veteran population is that it's these young folks coming back from service, particularly in the first year and up to 2 years after separating for service, is this period of time where folks are really struggling in their adjustment back to civilian life and where we really see the highest risk. Now, if you look at the method of suicide, you'll see, not surprisingly, that the vast majority of suicides are as a result of firearms. So if we compare this to our civilian population, what we find is that even in the civilian population, about 50% of suicide deaths are as a result of firearms. It's actually 50.4, so just a little over 50%. This means that more people in the United States die by suicide using firearms than all other methods combined. It's really important to pay attention to this particular methodology that's used so frequently here in the United States, and yet in the veteran population, we see that there's an even higher rate, with 67% of veteran suicides occurring as a result of use of firearms, with females using firearms disproportionately as compared to their civilian counterparts. So we see female veterans feeling a lot more comfortable using, they have, you know, the training, the acquired ability, the comfortability with firearms, and therefore we're seeing much, much, much higher rates of suicide deaths by firearms in our female veterans than we see in their civilian counterparts. Now, if we start to kind of hone in here on California to get a little bit of an idea of what's happening here in California, we see some similarities and yet some significant differences. So similar to our national rates, similar to our veteran rates, more than twice as many people die by suicide in California annually than from homicide. So we're seeing a higher rate of suicide by far as compared to homicides, as well as those war-related deaths. It's the 11th leading cause of death here in California. And in fact, here in the state of California, we tend to see a much lower suicide rate than when we compare it to our national average. So if you guys remember from 2 slides ago, our national average, our national standardized suicide rate is 14 per 100,000, versus here in California, we see a standardized suicide rate that's 10.7 per 100,000, significantly lower, and yet still a really important issue to identify and tackle, because even here alone in California, somebody dies by suicide approximately every 2 hours. Huge numbers, even still, with this lower standardized suicide rate. But I want to point you guys to this right-hand side, looking at these comparative rates and looking at these national veteran rates versus the California veteran rates. So we know that nationally, the veteran rate for suicide is significantly higher than the national suicide rate for their civilian counterparts. We've already kind of addressed that in the first 2 slides. And yet here in California, where there's a lower suicide rate, we see that the California veteran standardized suicide rate is higher than even the national veteran suicide rate. So we're looking at 30.1 for the national standardized suicide rate versus 39.1 here in California. What this means is that here in California, veterans are 4 times more likely to die by suicide than their civilian counterparts. So in the rest of the nation, we're seeing an increase in risk that's about 1.5 or 2 times the risk. And here in California, it's 5 times more likely that a veteran will die by suicide. This is really, really, really important information for us to pay attention to, especially as we kind of consider that California is the state with the largest veteran population in the nation. So I want to kind of talk to you guys about why I'm telling you guys about all of this data. This data is the exact type of information that led to the Office of Mental Health and Suicide Prevention out at VA Central Office to say we need to do something about this issue, we need to better understand, which really led them to engage in that comprehensive report that was published in 2016. And in that report, they found a few things. They found some of the data I just presented to you guys, such as the fact that 20 veterans are dying each day by suicide. But they also found something else that was really interesting as they were finally able to look at VHA utilizing veterans versus non-VHA utilizing veterans and even start to compare those rates. What they found was that of those 20 veterans that die each day by suicide, only 6 are using VA healthcare. 14 of those 20, 70%, are actually either engaged in care in the community or not enrolled in any services at all. We're not even quite sure what's happening with those folks because there's very, very, very little that we know about them. But I think it really created this a light bulb moment for OMHSP to say, wait, we need to really start to take a public health approach to suicide prevention. We really need to start to engage our community problems. We really need to start moving away from this thought of this is a VA issue and really understanding that this is a community issue so that we're really engaging all of those veterans, no matter where they're receiving care, and bringing in those veterans who aren't accessing care at all. And these folks identified some individuals who were particularly at risk for suicide, those that had a dishonorable or other than honorable discharge status, those folks that were homeless and have housing insecurity, recent separation from service, just like we talked about, combat exposure, or other types of trauma such as MST, those who are just as involved, elderly, socially isolated, those with physical and chronic pain diagnostics, and those with interpersonal relationship problems. So these are the considerations. These are the folks that we want to tackle that might be our most vulnerable population, where we're already seeing high rates in the larger VA population. So what they did was they joined forces with SAMHSA, and they worked with the CDC to really better understand the CDC's public health approach, including 7 different strategies to prevent suicide, really taking this holistic public health approach, thinking about what can we do to really create an environment where people are going to flourish, creating this upstream approach, not just identifying people in a time of crisis, which we absolutely want to do and will continue to work to do, but maybe also starting to identify risk factors earlier on and taking an upstream approach, preventing crises whenever we can. And so they talked about these 7 different factors. They talked about things like strengthening economic supports, strengthening access and delivery of suicide care, creating protective environments, talking a lot about lethal means counseling, reducing access to lethal means safety, things like that. promoting connectedness, something that's really important for us to start to think about in this time of COVID-19, where isolation is at an all-time high. Teaching coping and problem solving skills, so really kind of tackling those effective interventions that we can even do even with one encounter with a patient. Identifying and supporting people at risk, so how do we really kind of engage this public health approach by bringing in our gatekeepers and helping that identification process with really kind of bringing in our non-behavioral health providers that can, and teaching them how to make the referrals so that we can get those folks into care, and lessening harms and preventing future risk. So these are really the things that we want to tackle. And what the CDC did was they created a technical manual that talked about how to integrate all of these different things and how to really work together with a group of stakeholders to start to develop programming that would be idiographic, specific to the community that you're living in. And that's exactly what we sought out to do. So we brought together a group of stakeholders and we signed up for what is referred to as the Mayor's Challenge for Suicide Prevention. And we were very strategic in bringing our stakeholders. We brought in folks that were passionate about trying to reduce our suicide rates here in LA County and that would be committed and devoted to this endeavor. We brought in folks from all over. I don't even think that everybody is probably represented here on this slide. So I want to just start with a disclaimer of apologizing for anybody I've overlooked. We've had such incredible contributors and just supporters and participants in this initiative, and which continues to grow. But we've had our local law enforcement, our Sheriff's Department, our LAPD. We've had representation from the Mayor's office, and not just Lisa Salazar, who's been my co-lead on this project, but also folks from the crisis response team out of Mayor Garcetti's office. We've had so much representation out of our county representatives, from support from our county supervisors to the Department of Mental Health, to the Veterans Peer Access Network, who have been huge advocates of helping to navigate complex system and supporting our veterans, to our medical examiner and coroner's office, who have been incredibly supportive in trying to help initiatives around increasing our surveillance and really guiding our preventative efforts. We've had SAMHSA support and Dee Hirsch, MHSOAC, the Mental Health Services and Oversight Accountability Commission. We've had representation from 211 and from Inner City Law and UCLA and so many others who have just continued to work together in really tackling this issue, really focusing on those 7 core components that the CDC sought out. And we've done a lot. We've really done a lot. I'm really impressed with our team. We've been deemed a gold standard team that has been a model team that central office has taken really kind of as a model to help other teams in other counties and other states to really replicate some of the work that we've done, which has been incredibly innovative. From working with a bunch of strategic partners to continue to incorporate and develop workforce opportunities specific to veterans, to really thinking about preventative efforts. One of the first things that we did when we returned back from DC after an intensive week of working together was we worked with our local law enforcement to ensure that all of our crisis response teams, so our LAPD SMART teams, our Sheriff Met teams, are attending to veteran status and asking about suicide. And so we worked with them to change their electronic records and incorporate some really key critical questions into their assessment and screening processes as they're going out to engage crisis responses in the community. And they started to ask, have you ever served in the US military? So now we have documentation and accounting of how many times our local law enforcement are engaging our veterans in crisis. And then they went one step further. They said, we want to assess for suicide. And they incorporated 2 questions out of the CSSRS, the Columbia scale, which has been deemed a gold standard scale and is consistent with what the VA is using, what the DoD is using, and what the Department of Mental Health is using. So we have our law enforcement asking these screening questions consistent with the data that we're already collecting in all of these other agencies. And then others sought after that. Others kind of saw that modeling and continued in that same kind of direction. And before we knew it, we had Dee Hirsch saying, we're going to do the same. We're going to incorporate questions to assess for veteran status in our screening measures at Dee Hirsch as we're engaging with a large suicidal population. And so we had others starting to assess these things and starting to engage, starting to participate, really enhancing that universal screening to identify those folks at risk and help get them connected however they get connected, whether it's at the VA, whether it's through the Department of Mental Health, whether they need connection with VBA, whether it's connecting them with VPAN, it didn't matter, but let's get them connected. And then we have the peer support collaborative, really talking about how do we engage peer supports in a way to help this veteran population really be able to navigate these incredibly complex systems in a county as large and complex as we have. And then we really have folks like Jim Zenner who are heading up these huge initiatives that have been unprecedented, not just in the nation, but globally. I haven't heard of any initiative so large, and really kind of furthering this initiative to have a core group of peers that are trained intensively and that work together across agencies to help veterans navigate during these vulnerable times. We talk a lot about lethal means. Some things that we've done included participation in the first ever Suicide Prevention Commission. And through that, we were able to really communicate with the commission how important it was to address veteran-specific issues here in the state of California. And through our engagement with the Suicide Prevention Commission, through our work with the Office of Mental Health Oversight Committee, we were able to actually provide feedback that they incorporated identifying veterans as a vulnerable population and as a target group of focus in our 10-year plan for suicide prevention for the entire state of California. We were also able to push Senate Bill 172 that was signed into law by Governor Newsom October 12th, 2019, that allowed for the transfer of lethal means for individuals who are in a state of crisis and might be a danger to themselves. We were able to increase education by getting special grants. I have just a couple of examples of grants and training, but there's so much more training that has occurred, not just through special grants where we have been able to enhance training around suicide prevention, but also a great deal of military cultural training that has been incorporated in different agencies already, law enforcement, first responders, our firefighters. So many folks in our community are so eager and willing to say, I want to do better. How do I better serve those who served? That have jumped on and say, teach me. We want to learn. How can we be more culturally competent? And tons of training has come out in the last few years. Post-vention options and really engaging Mayor Garcetti's crisis response team, providing them training in military cultural competence, helping them to understand the specialized resources and referrals that may be needed for a military connected family and how to best support those individuals and how to get them connected with the services that are available within the county. And then getting certification in post-vention services such as survivors of suicide attempts group and things like that, those kind of evidence-based treatments that we want to make more available and accessible to our veteran populations. And then some surveillance efforts, which have been really fruitful, but are incredibly important. So our incredible collaboration with the medical examiner and coroner's office, and a huge shout out to Dr. Lucas, who has been so supportive despite the industrious schedule of the medical examiner's office and the push and pull competing demands, the undying support to say it is important for us to understand the suicides even after the fact, so that we can really take that information to help us guide our preventative efforts, and our hopes to develop a suicide review board, which I'll talk about in just a couple of moments. So I know there's a couple of familiar names that I see already in our participants, and for those who know me already, know that I'm a huge geek. I'm a total data nerd. So who cares about the numbers? Why do we even care about these numbers? Who cares about these standardized suicide rates of N per 100,000? And why does all of this matter? It's really simple. Understanding the risk factors that are associated with suicide deaths here in LA County allows me to essentially use that as a needs assessment. If I know which of my veterans are most at risk, then I know which of my veterans to best tackle with as much support that possibly I can, right? It allows me to identify those folks that might need more help, those geographic areas that might need more outreach, those demographics that might need more attention, that have been falling between the cracks and we might not even be knowing. So it's important for us to really kind of better understand the unique, the social, the health, the economic issues that are associated with suicide. If I know that, then I can know how to tackle it. If I see a high rate of suicide for individuals that have chronic pain, well, I want to pay more attention to those individuals that have chronic pain and go through all of the hospitals and train our pain clinics to better assess for suicide. If I see that there's a high rate of suicide that occurs after people are dropping off their pets at vets or shelters or pounds, well, then maybe I need to outreach those folks and help to train them as our unique gatekeepers. But I need to know what are the unique social, health, and economic issues so that I could tackle them for our population here. That will allow me to essentially develop these idiographic recommendations that will help guide our preventative efforts. These recommendations that are really tailored to our population here in Los Angeles County. So here's some of the data. We looked at every single suicide that had occurred here in Los Angeles County over the course of 5 years. And what we found was that we were able to confirm of those suicides, 5.9% of those were confirmed veterans. Of that 5.9%, 96% of those were male. And there was another 5.3% that we were unable to identify whether or not they were veterans. So we have about this 88% that are definitively not veterans, this 5.9% that are absolutely veterans, and this 5.3% where these are individuals where we access DoD records. We were able to see that they were in some way connected with DoD records, but then they were not enrolled in VHA healthcare services. So what this means is, are they likely veterans? Absolutely possible that a large proportion of these individuals are veterans that never accessed VHA healthcare. Makes sense. We know that about 50% of our veteran population engages VHA and about 50% does not. So it would make sense that a large majority of these are veterans. But we couldn't definitively determine that because it is possible that those military family members, that those may have been military family members that may have accessed services through the DoD as a military spouse, as a military child, and therefore were not enrolled. So because we could not definitively determine their veteran status, we separated this out into 2 separate groups and looked at the data among the 2 separate groups. But I want you guys to pay attention to this for just one moment, because even in this very little data that we have, there's some really compelling information here. There are about 280 veterans here in Los Angeles County, little under 300,000, 280,000 veterans here in Los Angeles County, of about 10 million citizens in LA County population, right? So we're looking at a veteran population that comprises about 2.8% of LA County's larger population. And yet for our confirmed veterans alone, we're seeing that they're comprising almost 6% of the suicides. And if we were able to verify that other group, it could be possible that veterans are comprising up until 11.2% of our suicides. So this population that's making up only 2.8% of our LA County population is making up anywhere between 6 to 11.2% of our actual suicide decedents. That's really scary. That's compelling data. That says to me, we need to pay attention to this vulnerable population who's dying at such a higher rate by suicide than their civilian counterparts. We have a little bit of information here about race and ethnicity. Similar to our civilian population, we see that the vast majority of suicide deaths are comprised of our Caucasian population. And then you see smaller rates for Hispanic, African Americans, Asian, and so on and so forth. When we look at our age demographics, we see a little bit of a different picture here in LA County as compared to what we're seeing in our national veteran suicide rates. So nationally, what the data says to me is it's my youngest folks, my OEF, OIF, OND veterans between the ages 20 and 34 that have recently returned from service that are at highest risk. Here too, they are at a particularly high risk, but we see that we have one age group that has an even higher risk for some reason, that 50 to 59 age group. And I'm not sure why that is. It would be important to really delve into understanding what occurred in each and every single one of those suicides so that we could better understand the risk factors associated. But we're seeing a little bit of a divergence here in our age group here in LA County. Not surprisingly, when we're looking at kind of our war era, and here we're only looking at our confirmed veterans, but here when we're looking at our war era, it's pretty consistent with the age groups that we just saw on the previous slide. So it's not surprising at all. And when we look at our suicide means, what we see is also interesting. So while death as a result of gunshot wounds accounts for 51% of suicides, that's pretty consistent with our civilian data, saying that just a little over half are dying by firearms. So again, similar to our civilian population, we're seeing that more people are dying by suicide using firearms in LA County veterans than by all other means combined. But this is lower than the national rate for veteran suicide. So we're seeing higher rate of suicide deaths, even though we're seeing a higher rate of suicides here in LA County and in California. Does that make sense? So we have a higher rate of suicide deaths for a veteran population in LA County and in California, but the methodology is a little bit different and we see a little bit more of a variance. All right, I'm not seeing any questions in the Q&A, so hopefully that makes sense. And here we just really have a breakdown of the location of suicide, really kind of showing those suicide decedents where they died, with the largest proportion of suicide decedents dying inside their residence. So what are our next steps? What do we need to do to go from here to actually take this data and bring it another step? Because the data that we have helps to give us some information, but it's lacking in many ways, right? Even half of those numbers, we're not even able to determine whether these folks are veterans or if they're not veterans. I don't even know, if I'm looking at half of my population base or what's going on. And so our data is lacking in many, many, many different ways. So the way to actually account for this and a way for us to actually take some steps forward in creating some holistic data is to create what's called a suicide review team. Suicide review board, a suicide review team, a suicide review committee. These are used interchangeably in different counties and different states that have developed these efforts. But the idea is to work closely, a multi-agency group of individuals that will meet monthly to review every veteran suicide that has occurred in LA County and to take a deep dive. So not to do this retrospective data analysis that we just recently did going back 5 years, but rather to take more of a proactive approach in understanding what are the risk factors in every single suicide. What happened? Understanding the story behind the suicide. Was there relationship difficulties? Was there a job loss? Was there financial issues? Was there housing issues? Was there chronic pain? Was there mental health issues? So many risk factors that we know exist in the literature, and yet what's going on for this particular individual? So that we could start to identify what are the patterns here for our county? Who are vulnerable populations here in LA County? And so in order to do that, what we would need is a multi-agency group, individuals from different agencies who can provide information to give this holistic kind of story of what is the narrative of this suicide decedents that would maintain this in a confidential way that is compliant with HIPAA and privacy laws, that would be able to better understand and aggregate this information and take that information to really help inform us in the future. So it's not just getting the information is informative, but it doesn't do anything unless we take it a next step. So what we need to do is we need to take this information and understand it best so that it can help guide us. And once we understand what's happening in our county, that will allow this group to essentially develop idiographic recommendations for our population. If I know who are the folks at risk here in LA County, who are my veterans at risk here in LA County, well, then I can work together with these stakeholders to really start to think about what can we do to help support these folks at risk. And that's our hope. That's our hope for kind of our next step. So I talked to you guys a little bit about how the Mayor's Challenge came about, what kind of started these efforts, how our team started here in Los Angeles, some of the stuff that we've done, and some of our next steps moving forward. I'd like to introduce folks to the team. Again, I'm going to offer my apologies. This is my favorite slide because this is truly just a slide with faces of individuals who are so dedicated, devoted, committed, who have taken this Mayor's Challenge as an ancillary duty above and beyond all of their regular roles and responsibilities, and continue to be devoted to the mission of serving those who've served. So I just want to truly express my deepest gratitude to all of those individuals who participate in the Mayor's Challenge, whether you guys come once a year, every single month, whatever you guys contribute is a huge contribution. And I'm just forever grateful for all of that support as we continue our efforts here, you know, even today in Suicide Prevention Month, and have our continued support from all of our collaborators. With that being said, with my thanks, and I'll go ahead and leave the slide up with some of our team members, I do just want to take a pause to just check in to see if there are any questions from the audience before I pass over the microphone to our next speaker.
So Dr. Berman, if you go under Q&A, you'll see the questions.
All right, and Giselle, I know that we have our next speaker waiting in the queue. Are there any questions that you want me to kind of highlight in responding to? I probably won't be able to respond to all of them, but is there anything you want me to focus on in particular?
No, maybe one question if you want, and answers to the questions through a follow-up email.
That sounds good.
Yeah.
I'll go ahead and just go with the first one just because it's the one on top. So Tom, you know, the COVID crisis does not shift a focus to suicide. I think that there's been an increased focus on suicide over the past decade, really with, you know, even VHA's secretary saying that this is our #1 mission. Suicide rates have increased in the DoD. Our National Guard rates have been at an all-time high and continue to be elevated as op-tempo has increased for our National Guard, and our veteran suicide rates continue to climb. So this has been an increased focus over the past decade, with more research coming out in the last 10 years than in probably the 100 years preceding. Yet I do think that there should be a special attention to this increased risk during this COVID crisis. So I do just want to kind of put a shout out there for all of the agencies. There have been more resources that I have seen out of LA County than I have seen in any other county or state, truly coming out to support individuals in need during this time of COVID crisis. And yet I think that we need to just be attuned that people are struggling in many different ways. So thinking back to the CDC's approach, thinking about economic difficulties and those struggles, housing insecurities and those struggles, isolation and withdraw, and how isolated we are these days as a result of COVID, where we certainly do estimate an increase in mental health symptomatology as a result of of the COVID kind of, not just because of the medical implications of COVID, but all of the effects of the isolation, of the withdrawal, of all of those things. So we certainly do anticipate an increase in mental health symptomatology. And many experts are assuming that there will be an increase in suicide rates. We won't know that definitively until a few years out, right? We're still in the midst of the pandemic, and so we'll have to wait 2-3 years after the completion of the pandemic to assess whether suicide rates increased or not. But the best experts in the field are certainly estimating that there will be an increase in mental health symptomatology and suicide rates as a result of the exact struggles that would essentially lend to increased risk in anybody, in our civilian, veteran, or active duty populations. I hope that answers your question. I don't want to take any more time up because I know there are other folks waiting to speak. So Giselle, I will go ahead and pass the microphone back on to you to introduce our next speaker, and I will try my best to answer these questions at a later time. Thank you for having me.
Thank you so much, Dr. Berman. Our next speaker is Supervisor Kathryn Barger, Chair of the Los Angeles County Board of Supervisors, and proudly serves the residents of the 5th Supervisorial District, which includes the Antelope, San Gabriel, San Fernando, Crescenta, and Santa Clarita Valley. Today, she will be talking to us a bit about local and national efforts underway to address veteran suicide. Supervisor Barger, we're ready whenever you are.
Well, first of all, thank you so much. It is my honor to join the Los Angeles Veterans Collaborative this morning. It has been an eventful year, to say the least. And throughout this process, I have been immensely grateful for the partnerships we have reinforced and the new ones we have fostered as we respond to the needs of the veteran community. The public health pandemic has forced us all to adapt how we do things internally at the county and externally with our county partners. We've worked with the state and federal governments to address challenges presented by COVID-19 while simultaneously providing the same critical county services that we always have. Through these efforts, we were able to receive assistance from the National Guard, which provided medical personnel to staff skilled nursing facilities. We've also received help from the Navy, which sent the U.S. naval ship Mercy to relieve the strain on our local hospitals. I would like to acknowledge the nearly 700 county employees who are concurrently serving in the armed forces through the reserves and the National Guard. It is important that we also acknowledge that the military is a part of the fabric of this county. Most recent data published by the Department of Defense indicates that in 2018, more than $10 billion were spent in the county in defense contracting and personal spending. To further this reputation and impact, the city of Palmdale is currently vying to be the home of the Space Force headquarters, and I invite you to join us in support of this effort. It is incredibly exciting at this prospect. There are many reasons military and veterans issues should be at the top of our minds. September serves as a reminder of the legacy of our veterans and servicemen and women, and the challenges we must continue to tackle on their behalf. September 2nd marked the 75th anniversary of the signing of the Japan Instrument of Surrender aboard the USS Missouri. And this week, September 11th, will mark the 19th anniversary of the attack on the World Trade Center, marking the era of the post-9/11 veteran. This month highlights our past as we recognize the greatest generation, our present, as we offer support for those who have answered the call to serve in the post-9/11 era, and our future, as we acknowledge that many who are beginning service were born after the tragedy of 9/11. September is also Suicide Prevention Month. Most of you know the statistic that an estimated 20 veterans are lost to suicide every day. However, we must acknowledge this is more than just a statistic. This is a call to action. Collectively, we need to strive to destigmatize issues of mental health and normalize open and honest conversations. I recognize that the most recent data provided by the state of California indicates that in Los Angeles County, we lost 93 veterans to suicide in 2017. Given that the best data available to us is a few years behind, I would like to acknowledge the collaborative work by the members of the Los Angeles Mayor Suicide Challenge. This team worked in conjunction with my office, the Office of Supervisor Kuehl, and the Department of Medical Examiner Coroner. Together, we sought deeper understanding about countywide suicides and combed through 5 years of data to identify veteran suicide locally. You've seen some of the preliminary work already, and my office is diligently working to push forward with county action to allow this data to be collected in real time. Additionally, we are working to explore the creation of a countywide veteran death review team, bringing together experts in our community to help us better understand this issue. Through these efforts, we continue working to align ourselves to ensure we have a better understanding of the veterans we continue to lose to suicide across Los Angeles County. I'd like to thank Dr. Sharon Birman, Lisa Salazar, and Mayor Garcetti's office, the Department of Mental Health, the Sheriff's Department, and the other partners who have actively worked through this challenge, especially someone on my team, Roberto Alvarez, who is passionate about this and dedicated to working toward addressing this issue. I encourage each of you to tune in on Friday, September 11th for day 3 of the Los Angeles County Suicide Prevention Network's annual summit, which will focus on veteran and first responder suicide prevention. To better respond to incidents of mental health crisis, the Sheriff's Department Mental Health Evaluation Team created the Veterans Mental Health Evaluation Team in collaboration with the Long Beach VA. This collaborative effort is a team of mental health experts partnered with law enforcement to respond to the calls where a veteran is in crisis. Because of these teams, we can divert veterans to the VA to connect them with the proper treatment. Our sheriff's deputies are also undergoing veterans competency training. This helps deputies on patrol understand these calls require a different lens. The Veterans Mental Evaluation Team helps de-escalate the situation and connect the veteran in a crisis with the VA. We know one of the most effective ways to serve veterans is with the help of other veterans. I am proud to have co-authored an initiative that created the Los Angeles County Veteran Peer Access Network. Known as VPAN, the effort helps us work more collaboratively to maximize the resources available to veterans, service members, and to their families. We are aligning how the county serves this community while also working collaboratively with the federal, state, and community partners to bridge services and augment our efforts. As we get closer to the full implementation of this program, I would like to acknowledge our director, Dr. Jonathan Sharon, and Jim Zenner from the Department of Mental Health for their leadership. I encourage our community partners who serve veterans to participate in the request for proposal through the Southern California grant makers. It is more evident than ever that we need to collaborate. The most recent LASA homeless count shows that there were 877 sheltered and 2,804 unsheltered veterans in Los Angeles County, although I think those numbers are low as it relates to those that are unsheltered. BASH vouchers are another indicator, and the Los Angeles County Development Authority reports 71% utilization. These veterans desperately need our help. Too often, veterans are falling through the cracks. To date, I have adjourned our Board of Supervisors meeting in memory of 120 indigent veterans who died in this county. Through a partnership with the Medical Examiner and Riverside National Cemetery, these veterans were transferred to be buried with dignity and military honors. I strongly believe that homeless and veterans should never be used in the same sentence. That is why I also co-authored a motion with Supervisor Kuehl in October 2018 to provide funding for the bridge housing that recently opened on the West LA campus. And recently, Supervisor Kuehl and I sent a letter to the Secretary of the VA expressing our support for the housing development at the West LA VA campus. During the COVID crisis, we have enrolled 138 homeless veterans into the Project Room Key program, which has housed them in motels and hotels that would have otherwise gone unused. With the support of our federal partners and the VA's increased funding for supportive services for veterans and their families, we have enrolled roughly 600 veterans into emergency housing assistance. In addition to housing, we have worked to equip our veterans with sustainable careers. My office has allocated $1 million in training funding to support our aerospace partners in the Antelope Valley to hire veterans for high-paying jobs. This morphed into a further collaboration as our Workforce Development and Aging and Community Services Department increased their scope to improve relationships and partnerships to provide more employment prospects for veterans across the county. Meanwhile, our veteran service officers through the County Department of Military and Veterans Affairs have continued providing services to our veterans amid this pandemic. We need to advocate for our veteran service officers at the state level. Despite previous commitments by the state to provide half of the funding for the VSOs, as it currently stands, data from all counties statewide indicate that counties provide 77% of the funding for these services. Moreover, in Los Angeles County, we are still only seeing a 25.4% utilization rate of veterans receiving compensation or pension benefits from the VA. I invite you to regularly attend the county's Veteran Advisory Commission, where each supervisor has appointed 2 commissioners to help us better understand veterans' issues in our community. Lastly, I would like to ask that we all complete the census. In 2010, Los Angeles County had a significant undercount. That means we lost hundreds of millions of dollars in federal funding over the last decade. We can't let another 10 years pass without adequate counting or adequate funding, which will help us maximize the necessary resources and representation for our veterans here in Los Angeles County. I am hopeful that together we can continue to make Los Angeles County more responsive to the needs of the veterans and the military community. I am so grateful for your interest in this important issue and your continued partnership in these efforts. And I would like to thank all the veterans for their service. Thank you.
Thank you so much, Supervisor Barger, for giving us a bit of your time to share this information with the collaborative.
My pleasure.
And thank you everyone for staying on. I know we are a bit over time. I'd like to quickly introduce our next speaker, Ms. Marcia Stevenson, Program Administrator with the Los Angeles County Office of the CEO. And she will discuss the 2020 census and the upcoming deadline.
Unfortunately, it appears that Marcia Stevenson's having technical difficulties on her end. So we're gonna end the meeting at this point. Thank you everyone for joining us today. I'd like to thank our guest speakers, Dr. Sharon Birman and Supervisor Kathryn Barger for joining us today. I'd also like to thank Marcia Stevenson. Unfortunately, she wasn't able to share her information and presentation, but we'll do that in the follow-up email. Make sure to review the agenda, which was included in the registrant email, to join the breakout groups.